Well, thank you very much. I have the hard task to show that alkylators are essential in the treatment of myeloma. I'm actually in the middle, so I'm not so sure. And I have to say that coming from Europe, where we were definitely in favor of alkylating agent, I have to say that after years, the US people probably were ahead of us in defining the role of this treatment. But still, alkylating have a role. We are now talking about transplant-ineligible patients, but I would like to take the model of transplant to make a point. You can see here from a randomized trial where basically you were comparing low-dose melphalan versus high-dose melphalan, that high-dose melphalan makes a difference in terms of progression-free survival, so the alkylating agents are certainly effective in treatment myeloma. They do have a role in the treatment of this disease, and you can see it from this randomized trial that the higher doses of melphalan is significantly improving the progression-free survival. And you can even see it, and this again is a randomized fashion, when you divided the 4 groups, you can clearly see the adding value of the high-dose melphalan versus the low-dose melphalan. And you can see here in the red curve where you have the autologous transplant followed by maintenance. The blue is the autologous transplant. The yellow is the low-dose melphalan with maintenance, and below there is the low-dose melphalan without maintenance. So clearly there is a role of melphalan in improving the efficacy of myeloma treatment. Then there is another story, and the story is if you compare patients that are achieving CR. So we are selecting all patients who are in CR after treatment. There is a difference. So CR is not telling us everything. Even if they are both in CR, and you can see here in the yellow curve, when again you see the autologous transplant versus the conventional treatment, they do better. So once again, even if you are talking and you are selecting patient in CR, the autologous transplant is doing something. Why that? Because myeloma experts, they keep calling CR what is not a CR, because immunofixation negative CR is definitely not a CR. And melphalan, if you look at the MRD level, is doing something more. So within the CR, you can see it here in the higher bar, where the MRD is negative. In the lower, and the square is all immunofixation negative CR, there is still a residual disease. So behind the CR, the melphalan is improving the response you might just see with a low dose of melphalan. So please do not compare CR. This will be my first message when you try to make a statement. Do compare progression-free survival, at least in order to evaluate the efficacy of a treatment. So now let's see what we have in terms of standard of care. Of course, I'm talking about what especially we do in Europe. You look at MPT here, median survival 39 months, median progression-free survival 20 months. These are the numbers are coming from the typical MPT study. If you move to MPV, and if you make a more intense treatment with alkylating agent, the progression-free survival is 3 years. The time to next treatment is 46 months. And this is my first challenge with my opponent. And the first challenge is that today, if you look at the randomized study, and you look at a follow-up of 5 years almost, median age 71 years, to have a progression-free survival of 3 years and a time to next treatment of 46 months, in the conventional treatment, I invite my opponent to show similar results in other settings. Which are the limitations of melphalan? There are limitations. The first limitation is melphalan is given cancer. We have been seeing, looking at the story of lenalidomide, mainly the reason of second cancer, hematologic cancer, was coming from a combination with melphalan. So melphalan is an old story, but is inducing MDS. But more important than that, and I was always very much impressed by this data that was totally unexpected, because we were looking to SPM and we realized that especially combination including melphalan were dramatically increasing the death for toxicity. And this was a minus, because you can see here from this cartoon that the incidence of death for myeloma is 35, maybe as high as 18 for toxicity, and maybe 1 or 2 or 3% for SPM. So, dear opponent, I'm getting close to you. You start to have some right. The balance is melphalan, and if we want to make a statement here, melphalan is important, but has some relevant toxicity that must be taken into account. So, which are the alternatives? This is coming again from my opponent. The alternatives is certainly cyclophosphamide, and his is a study that has been done by the Mayo Clinic, where cyclo was compared with VCD, was compared with VRD, and with the 4-drug combination. Don't go in detail, no major difference between the different combinations. So cyclo, len, cyclo-len together, they are not clearly making a major difference. If you look at which are the combination today, so which is my point, probably not melphalan, probably cyclophosphamide should be taken in consideration. Here is a combination of bortezomib, cyclodex. Unfortunately, we do not have randomized trial. We do not have a longer follow-up, but still 47% of CR, certainly a very nice response rate. Moving forward, carfilzomib, cyclophosphamide, and dexamethasone. Here we are going up to 65% of the CR rate, so certainly we need to see the remission duration, but certainly in terms of response, very nice results. But there is again one issue. In this aging world, especially Europe and US, 40% of myeloma patients have more than 75 years of age. So here is again a condition where the third drug, where an alkylating agent might create a trouble. So my suggestion, and I'm opening this door, is geriatric assessment should be done in all elderly patients. This is essential to reduce toxicity. Do whatever, there are many of them, but certainly to see, and divided the fit from the unfit from the frail, the geriatric assessment must be done in the elderly frail population. And I show this curve to you because this is a trial where you simply compare the age, younger or older than 75, younger or older 80, no problem, no difference. But when you start to put inside the geriatric assessment, look at the difference between the fit and the frail, both in terms of overall survival and progression-free survival. This is telling us that age by itself is not dividing the two patient population. The geriatric assessment is essential in this patient subgroup. Of course, I'm not going in detail, reduce the dose intensity, but the other issue is probably in this patient, and again here I'm getting close to my opponent, 2 drugs must be delivered. These are actually 3 different randomized trials comparing 2 drug versus 3 drug, melphalan, cyclophosphamide, thalidomide, in a very elderly, frail population, no major difference. So once again, the message is maybe alkylating are important in the fit, but in the frail, the two drug combinations should be considered first, and eventually, in this patient condition, start with two drugs, consolidate. This is a concept that is present in the transplant, should be also present in the elderly. You start with two drugs with a lower approach, then you consolidate eventually with an alkylating agent or another agent. But then for the maintenance, this is also the third concept, not always present. You need to lower the dose, because if you give a treatment for 2 to 3 years, you cannot keep going with the induction dose intensity for 2 to 3 years. So I'm getting to my conclusion, and the conclusion is for the fit, the triplet should be considered a standard. I'm probably moving from melphalan to cyclophosphamide, but still I'm saying something. Alkylating agents are definitely a major efficacy in myeloma treatment, at least until now. And for the unfit patient, probably the doublet should be preferred. This is my last one, and if I just have a very short commercial I have to give you. We are going to have the International Myeloma Workshop in 2 years from now in Rome in September, so you might possibly have some summer in Rome, followed by some autumn in New York. Thank you for the attention.